musculoskeletal disorders. We're going to be talking about arthritis, whether rheumatoid arthritis, osteoarthritis. We're going to be talking about gout, and finally we're going to be talking about osteoporosis. Let me start with rheumatoid arthritis. Rheumatoid arthritis. Yes, the name includes arthritis, but don't forget, rheumatoid is a systemic autoimmune inflammatory disorder. Systemic autoimmune inflammatory disorder. You have joint manifestations and you have general manifestations. The clinical presentation of rheumatoid arthritis, RA, most often in women, usually in the 50s. And it starts with a prodrome of malaise and weight loss. And then joint pain is going to follow. And whenever you get the joint pain, it's going to be multiple symmetrical joint affection. Rheumatoid arthritis never affects a single joint. It has to be at least 3. Multiple symmetrical joint affection. No one hurts more than the other. It's a systemic involvement. And what's very characteristic about RA, prolonged morning stiffness in multiple joints of the hand, lasting for more than 1 hour. Can you believe that? It takes the RA patients, it takes the rheumatoid arthritis patients more than 1 hour just to get to be able to open their hands. Very characteristic. And this symptomatic episode of arthritis will be going on for at least 6 weeks. For 6 weeks, you have this multiple joint pains, you have this prolonged morning stiffness for 6 weeks, and then the patient is going to improve a little bit, and then we'll pass into another symptomatic episode of arthritis. Notice, there is a viral infection caused by parvovirus B19 that will give similar clinical picture to rheumatoid arthritis. But here, in this viral, in arthritis, the symptoms last only for few days. But for the arthritis of rheumatoid arthritis, the symptoms will last for at least 6 weeks. This is how to differentiate between rheumatoid arthritis and parvovirus B19 infection. To diagnose rheumatoid arthritis, you need to have 4 or more of the following criteria. Number 1, and most important, morning stiffness lasting for more than 1 hour. Wrist and finger involvement, especially the metacarpophalangeal joints, the metacarpal, the knuckles, metacarpophalangeal joints, and the proximal interphalangeal joints. Characteristically, rheumatoid arthritis always spares the very distal joints of your fingers, the DIP, the distal interphalangeal joints. Swelling of at least 3 joints. Symmetric involvement. All your joints hurt to the same extent. All your joints show manifestations of inflammation to the same extent. Positive rheumatoid factor, or what's better now, anti-CCP factor, as we're going to explain in a moment, and elevated C-reactive protein, elevated ESR. Why? There's inflammation, a lot of inflammation. You can also have rheumatoid nodules, and you can also have X-ray abnormalities showing destructive lesions in the joint, erosions in the joint. As I said before, rheumatoid arthritis is a systemic disease. So you have arthritis and you have findings outside the joints. You can have cardiac manifestations, pericarditis, valvular disease. You can have lung involvement and you get pleural effusion, and characteristically very low glucose level in this pleural fluid. And you can get lung nodules. Blood, you get anemia with a normal sized red blood cells, normal MCV and anemia. This is rheumatoid arthritis. You can get mononeuritis multiplex. What's that? Only one nerve is inflamed and hurts, and commonly this nerve is the ulnar nerve. The ulnar nerve that passes here at your elbow is usually inflamed. And the skin, the most common finding outside the joint is skin nodules in rheumatoid arthritis. Okay, we have this mini case, 34-year-old woman with pains in both hands for a few months. Stiffness improves as the day goes on, and this is the characteristic clinical manifestation of rheumatoid arthritis. The worst time is early morning, and then when they loosen up and they start doing the daily activities, they improve. This is going to be opposite to osteoarthritis, because in osteoarthritis the activity is going to worsen the pain. Anyways, this lady has multiple joints are swollen, and the X-ray will show some erosions. So we have the criteria to diagnose rheumatoid arthritis. What is the single most accurate test to verify the diagnosis. Is it rheumatoid factor or is it this anticyclic citrullinated peptide, anti-CCP? Well, it is anticyclic citrullinated peptide. Rheumatoid factor is present only in 75 to 85% of patients. This means you can have rheumatoid disease, but your rheumatoid factor is negative. Not only that, it's not specific. It could be present in other diseases. So you can have positive rheumatoid factor, but you don't have rheumatoid disease. So what is a better test? A better test is anti-CCP. It's the single most accurate test for RA. It's over 95% specific for rheumatoid arthritis, and it appears earlier than rheumatoid factor in the course of the disease. Here are some joint findings in rheumatoid arthritis. Some joint deformities: swan neck deformity, botulnar deformity, ulnar deviation of the hands. And here is a serious joint affection. When the rheumatoid affects the C1, C2 joint, we get C1, C2 cervical spine subluxation. And this is serious if the patient was scheduled for surgery and the anesthesiologist was not aware of that. And hyperextension of the patient's neck can lead to fractures in this very sensitive, serious area. Baker cyst is inflamed, enlarged popliteal synovial membrane. So the synovial membrane in the popliteal fossa in the knee joint can get inflamed and enlarged. This is Baker cyst that is very painful, and it needs to be surgically removed. Treatment of rheumatoid arthritis. The standard of care is NSAIDs plus disease-modifying anti-rheumatoid drugs, or what we call DMARDs. This is the standard of care in rheumatoid arthritis. NSAIDs, like what? Any NSAID. NSAIDs here are just symptomatic. They do not delay the progression of the disease. They do not stop the progression of the autoimmune inflammatory process. They just improve the symptoms. But the DMARDs, these are the disease-modifying anti-rheumatic drugs. Now you are doing something to stop or to slow down the progression of the disease. These are the real medications for rheumatoid arthritis. But DMARDs, they take a long time to act. So you need to have a bridge therapy until your DMARDs have kicked in, and this bridge therapy is achieved by steroids. So how to treat rheumatoid arthritis? NSAIDs for the symptoms, DMARDs for the progression of the disease, steroids used for a short-term period as a bridge DMARD or a bridge anti-inflammatory until your DMARDs have kicked in. Give me some examples. Any NSAID. Ibuprofen is probably the most commonly used one. For DMARDs, give me an example. Well, the best and initial DMARD is methotrexate. Methotrexate, Rheumatrex, is the most commonly used medication for rheumatoid arthritis. But you can combine it with a tumor necrosis factor agent, which is a newer DMARD called the biologic DMARD. Like what? Infliximab, adalimumab, etanercept. Notice, these are strong immunosuppressant drugs. So one important thing you need to do here is test the patient for TB. If the patient's skin test for TB was positive, these drugs could lead to flaring up of his hidden dormant TB infection. Therefore, positive skin test for TB in any patient who needs these drugs for any indication, whether rheumatoid arthritis or any autoimmune disease, these patients will need a 9-month course of INH to make sure that the TB is not going to flare up when you start using these monoclonal antibodies or the biologic DMARDs. Alternate DMARDs, this is a full list of other DMARDs that can also be used in the treatment of rheumatoid arthritis.